My PhD work is on medication.
The tools of pharmacoepidemiology to evaluate the occurrence of medication errors and suspected adverse drug reactions in our healthcare setting. This work was conducted in 2 studies. The first one intended to evaluate the existing pharmacovigilance system in Uganda, and the second one aimed at determining the burden of adverse drug reactions and medication errors among inpatients in our setting, but with a focus on antibiotics and herbal medicines.
Introduction. Pharmacoepidemiology is a science that quantifies adverse drug reactions and patterns of drug use in large populations. Its advantage over randomized clinical trials is the ability to quantify rare, delayed, and unanticipated adverse drug reactions. It hinges on pharmacovigilance, a neglected science whose main role is to detect, assess, evaluate, and prevent ADRs and medication errors and other drug-related problems. A fully functional pharmacovigilance system should monitor adverse events related to the quality of products, previously known and unknown drug reactions, as well as medication errors. Over the past 60 years, pharmacovigilance has played a key role in the withdrawal of 462 harmful medicines worldwide. And it's interesting that 72% of these drug withdrawal decisions have been based on anecdotal evidence. Fewer than expected reports have been received from the African continent, probably because of its young pharmacovigilance systems. The withdrawal of counterfeit and substandard medicines has been documented in Uganda. For instance, in 2003, a batch of injectable chloroquine failed a quality test and it was withdrawn from the market. And as recent as November last year, several batches of an emergency contraceptive were withdrawn because they were found to contain no active ingredient of levonorgestrel. We define a defined daily dose, DDD, as the average daily dose of a drug given for its main indication among adults. And a suspected ADR as any undesirable medical occurrence that develops after the administration of a drug and with at least a possible causal relationship as measured by the Naranjo ADR probability scale. A medication error was any error during the medication use cycle, which is the prescription, transcription, dispensing, administration, and procurement stages. A comprehensive ADR description is one with at least 4 of the 5 ADR descriptors that we elicited in our data collection stage. A rare ADR is one that occurs in at most 1 individual for every 1,000 that are on specified medication. A serious ADR is one that threatens life and could actually result in death. Most often it may require initial or prolonged hospitalization and sometimes disability. And this should be differentiated from severity, which simply describes the intensity of an ADR as mild, moderate, severe, and so on. An unanticipated ADR is one whose relationship to the implicated medication is not known according to the existing literature. So what is the problem? Globally, the pharmacovigilance system relies a great deal on the reporting, usually spontaneously, by healthcare professionals. And the biggest challenge here is that underreporting is massive. The ability to discriminate between drug effects and disease effects can sometimes also be a nightmare. Little wonder more than 90% of ADRs in developed countries are unreported. In Uganda, a national pharmacovigilance center was established in 2005, and it currently has 14 regional pharmacovigilance centers. The NPC has conducted numerous trainings countrywide, and it has distributed ADR forms, particularly to the regional pharmacovigilance centers. However, the rate nationally of ADR reporting is still very low as one report for every 230 healthcare professionals. And for the few who report, over 80% do not contain the adequate information that would permit meaningful medication safety analysis. Currently, there is no formal system of reporting medication errors in Uganda. And so the fact that there's little known about the burden and determinants of ADRs and their reporting, and as well as the attitudes of healthcare professionals towards medication error reporting, we designed Study One to assess these. ADRs are the fourth leading cause of death in the United States and seventh in Sweden. Similar data are, however, lacking on the African continent. ADRs and medication errors are linked to higher morbidity and mortality and raise healthcare costs. The extent of ADRs and medication errors in our setting is not well known, and yet they are known to occur. For instance, the case of post-injection paralysis among children who were injected with quinine by unqualified healthcare professionals in eastern Uganda. Currently, there is a scarcity of electronic databases, and this is not helped by the inadequacies in the manual medical record-keeping practices in our setting. Now, this tends to limit our ability to detect signals, and therefore we end up underestimating medication risks. And so we designed a prospective pharmacoepidemiological study to study the patterns of medication use in our setting and to estimate the extent of ADRs and medication errors. This is a conceptual framework showing the various interrelationships between the four major categories of characteristics and the two main outcomes of our investigation, which is the reporting of ADRs and medication errors, and the second one being the actual occurrence of the suspected ADRs and medication errors. So those are the two layers, and so sub-studies 1 and 2. Now, according to James Reason, a British psychologist, the occurrence of human errors can be viewed from a personal approach with the intention of apportioning blame to the individual healthcare professional, or from the systems approach where you assess the organizational environment where healthcare professionals work. Now, if you focus on the personal approach, you are likely to have underreporting, because people will be fearing blame. However, if you look at the system approach, then you are more likely to encourage not only the reporting, but you're also aware that most errors arise from system failures. The hypotheses of this study were very interesting because at one point we were basically exploring what is out there. And so we did not have study hypotheses for those components. However, we also had explanatory components where we compared different study groups within the sample. And these actually required hypotheses. We employed both the statistical hypotheses as well as the empirical ones. The statistical ones were driven by the null, and our objective was to reject the null. And an example of this was in paper 6, where we were assessing the risk factors, one of them being herbal medicines. And so the null hypothesis was herbal medicine use in the 4 weeks prior to hospitalization increases the risk of developing a hospital-acquired suspected ADR among inpatients at Mulago Hospital. The empirical example we could give here is assessing the reporting of medication errors and ADRs by healthcare professionals will identify gaps that can be addressed to improve the practice of pharmacovigilance in Uganda. Study 1. The first study was conducted across the country in all the regions. We selected health facilities, both public and private. It was a cross-sectional study. We distributed self-administered questionnaires to 2,000 consented healthcare professionals who are involved in the prescribing, transcribing, dispensing, and administration of medicines. The return rate was 67% of the distributed questionnaires. Paper 1 addressed the extent and determinants of ADR recognition and ADR reporting. I'll be using the words detection and recognition interchangeably. Half of the healthcare professionals had never heard about pharmacovigilance, and worse still, 2/3 were not aware of the existence of the National Pharmacovigilance Center. 1 in 5 had recognized an ADR in the previous month, with a 60% detection rate per patient complaint to a healthcare professional in that month. 1 in 7 had reported an ADR in the previous year, just 2% being to the National Pharmacovigilance Center. We also got feedback from the respondents where they said that there was poor feedback from the NPC and from the district directors of health services, as well as from the drug manufacturers. Now, only 13% of all detected ADRs were reported. Amongst the factors associated with ADR recognition, private health facilities, we found also that non-nurses, that is doctors and pharmacists, and the diploma level as well, and those involved in medical research were more likely to detect ADRs. However, patient ADR complaint was the dominant factor, whereby healthcare professionals were 19 times more likely to recognize an adverse drug reaction. ADR reporting was more likely at the hospital level, in medicine, and also among healthcare professionals who had ever encountered a fatal ADR, those who knew to whom to report, and those who had suggested ways of improving adverse drug reaction reporting. We conclude from study 1 that nurses were less likely to detect ADRs. However, there was no difference in reporting rates by professional cadre. The pharmacovigilance system should encourage feedback to ADR reporters. For instance, when the analyses are done, it would be good to know what policy actions are taken. For the case of quinine injection paralysis, the policy was actually changed for children. The injection site was changed from the gluteus muscle, where they used to inject erroneously into the sciatic nerve and cause paralysis, to the thigh, where there was less likelihood for that risk. Now, most recognized ADRs were not reported, and this is consistent with the literature. We also conclude here that patients should be empowered to promote the detection and reporting of ADRs. We also designed an ADR form for inpatients that was tested in study 2. Shall we only focus on the quantity of ADR reports received? No, because we also need high enough quality in the reports for us to have meaningful medication safety analysis. And so we investigated how comprehensively Ugandan healthcare professionals describe their most recent ADR and the characteristics of those who had provided these comprehensive reports. We also identified the rare, serious, and unanticipated ADRs that arose from these descriptions. We were glad to note that of the healthcare professionals who had suspected an ADR in the previous month, up to 46% provided comprehensive reports, which was quite commendable. Comprehensive ADR descriptions were more likely from healthcare professionals who worked in the private sector and those in regions other than central Uganda. However, those who taught medical students were less likely to provide comprehensive ADR descriptions. We also identified serious, rare, and unanticipated ADRs and an estimate of up to 1.5 patient days if every healthcare professional had seen an average of 41 patients per day. Stevens-Johnson syndrome was the most common one. We conclude here that these mock reports actually demonstrated the ability of these healthcare professionals to describe the ADRs well. So what happens in routine care? Why is the quality of reports so poor? We think that this might partly be due to the low motivation, partly because of poor feedback, like I mentioned earlier, but also due to a heavy workload, but could also be due to little awareness of healthcare professionals, as we highlighted in the results. However, the case of incomprehensive ADR reports from healthcare professionals who make the first contact with future doctors, nurses, and along with other disciplines in healthcare. We think that this is a major blow to grassroots pharmacovigilance, and we shall discuss recommendations of this later. The Uganda National Pharmacovigilance Center is in the process of setting up a medication error reporting system. And we thought that this study came in handy to assess the attitudes of healthcare professionals towards medication error reporting. Now, the majority of them approved establishment of this system. However, 62% cited blame, which they thought would actually deter reporting. Impressively, though, 2/3 valued patient involvement in medication error reporting. And we conclude then from this study that a non-punitive systems approach should be used. The strength of study 1 was that we had a huge sample size of over 1,300 professionals from all regions of Uganda. And one major limitation was recall bias, which we attempted to manage by restricting the recall period to not more than a month or a year in the past. Now, taking a deep breath and equipped with the ADR form for inpatients that we had drafted, and the key findings from study 1, we felt confident enough to leap into study 2, which was conducted at the National Referral Hospital, Mulago, in the 3 medical wards. For those of you who are locally here, you know it's 4th floor and 1 gynecological ward. It was a prospective cohort study. It involved intensive collection of data. The only day we rested was the day that actually never existed, because we collected data 7 days a week. And each patient who was recruited was followed up till either discharge or transfer, death or loss to follow up. We had 4 teams, 1 on each ward, each comprised of a pharmacist, a medical doctor, and a degree nurse. And there were reasons why we went to that extent after doing the pilot. There were 762 healthcare professionals in all, with a loss to follow up of only 7%. We piloted the ADR form and realized that it was bulky, about 4 pages, and we were collecting data, a lot of data. And so we designed a tracking log which could capture up to 4 ADRs. And so we were able to reduce on the paper load. We used the Naranjo scale to measure an ADR and a trigger tool for ADRs to improve our ability to detect adverse drug reactions. Now, focusing on the tool for measuring these ADRs, it's a 10 questionnaire algorithm that gives a score for each question, and down there is where you'd have the total score. And so if you have 1 to 4 as your score, then there's a suggestion of the possibility of an ADR. However, if you have a score of 9 and above, that is a definite ADR. And the first paper in study 2 assessed the use of antibiotics as a way of demonstrating the occurrence of medication errors in our setting. 39% of these inpatients had used antibiotics before admission, and 79% were initiated on antibiotics during hospital stay. 1,985 defined daily doses of antibiotics were administered in 3,741 inpatient days. When we compared the prescription rate versus use, first of all, we observed that treatment duration was omitted by the prescriber in 7 to 8% of prescriptions of the most commonly prescribed antibiotics, which were ceftriaxone, ciprofloxacin, and metronidazole. And we observed that ceftriaxone had the highest number of total prescribed doses administered at 62%, whereas Cipro and Metro had only 35 and 27%. Moving on to assessing the completion rate of prescribed antibiotics, we observed that 97% of patients on metronidazole and 90% on ciprofloxacin were not able to complete their prescribed antibiotic therapy. Taking a closer look at the day-by-day consumption of, say here, ciprofloxacin for each patient, and this showing data for the first 10 days of the antibiotic as it is used, we observed that, the red showing here that all doses of Cipro having been missed, and Cipro is given twice a day. We summarize in this slide that the per day risk of missing all treatment of ciprofloxacin was 35%. However, this reduced to the range of 9 to 10% on days 2 to 5. So we took the illustration here just to show in this slide that now we aggregated data for, not aggregated, but we have a summary of data for the 5 most frequently used antibiotics. And we show here the per day risk for days 1 to 5. It is clear from this slide that the per day risk of missing treatment was highest on day 1, and which tended to reduce drastically over the subsequent days. Now, whereas the per day risk for the 4 antibiotics, azithro, cipro, ceftriaxone, and metronidazole, were similar, amoxicillin seemed to have a much lower per day risk. And the reason is that it was usually prescribed towards discharge. Now, having these similarities in the per day risk shows a system's weakness. And we conclude from this paper that most patients were exposed to antibiotics, which increased their risk for antibiotic-associated adverse drug reactions. There was a huge disparity between the quantity of antibiotics prescribed and those eventually consumed. And the per day risk, as observed, we tend to think that it might be the poor communication between the prescribers. If a prescriber gives a prescription and does not inform the patient, most likely by the time they find out, the patient will have lost time, valuable time. And then we also observed from our day-to-day stay on the wards that there was understaffing. And so if you imagine a nurse having to administer drugs to about 50 or 60 patients, naturally there would be delays in treatment. But also there were frequent drug stockouts. The 5th study assessed the extent of antibiotic-associated ADRs and their characteristics. And we observed that half of the patients who had encountered a hospital ADR had also experienced an antibiotic-associated hospital-acquired ADR. We also observed that 1 in 6 patients who had used antibiotics during hospital stay experienced an antibiotic-associated ADR. And 12 ADRs were observed for every 100 DDDs consumed. We were able to identify serious ADRs, which were 28% of the total, and 10% were rare. This is a list of the 20 serious antibiotic-associated ADRs that were linked to hospitalization. I highlight here anemia linked to the use of cotrimoxazole, and peripheral neuropathy associated with levofloxacin use. These two being the only rare ADRs, but which were actually preventable. Now, the ADR frequencies for each antibiotic were standardized according to consumption in DDDs, and that generated the signals that we needed on the safety of these antibiotics. And we observed that levofloxacin and ceftriaxone had the strongest signals, as well as metronidazole, and which were statistically significant. We would be quick to point your attention to levofloxacin, because despite its low consumption, it still showed that it was high risk in this population. So we conclude here that antibiotics contributed the highest burden of ADRs, probably due to high consumption as a result of high comorbidities. The risk of ADRs for each antibiotic should be gauged against its consumption. As observed in the previous slide, we identified levofloxacin despite its low consumption. So, there is a dilemma here. Ceftriaxone and levofloxacin are known to be generally safe. So why were there strong signals in this study? Could it be due to drug-drug interactions or drug-disease interactions? Or could it simply be due to impurities in these formulations? These questions elicit further investigations. As shown previously, we were able to identify avoidable, rare, and serious antibiotic-associated ADRs. In paper 6, we estimated now the overall incidence and risk factors for adverse drug reactions that were new in the hospital during hospital stay. And we also constructed an ADR risk score to predict and qualitatively assess for differences in the ADR cases. And we observed that the risk of a hospital-acquired ADR was high, showing that at least 1 in every 4 patients developed an ADR. Interesting, though, was that none of these ADRs was fatal. Antibiotics led this pack, followed by uterotonics, cardiovascular drugs, antimalarials, and opioid analgesics. The pre-admission use of herbal medicines and use of 6 or more conventional medicines precipitated the occurrence of these ADRs. Our risk score was able to detect qualitative differences between high-risk patients, these being the topmost distribution, the 10% of the ADR risk distribution, if you plot these probabilities of the risk. And when compared to the bottom 30%, which we classified as low risk. We conclude from this study that the risk was high, although when you compare this to what has been done elsewhere, it was up to 4 times higher than was observed in France. The developed and tested form was able to provide us with a tracking log, and this tracking log with fill can be used during routine care. If for every patient file we can insert this form, then we can be in a position to obtain this information and analyze it moving forward. The last paper assessed the use of herbal medicines and identified suspected ADRs linked to them. And we observed here that 2% of inpatients developed a herb-linked adverse drug reaction, one being linked to kidney injury and the other to abortion. And we conclude from this study that clinical elicitation was a cost-efficient method that can generate safety data on herbal medicine use. The strength of this study was that we piloted our tools and intensively followed up our patients. One limitation is that we had a small sample size that could not help us to validate the risk score that we had developed. Overall, we conclude that the recognition and reporting of ADRs was low. However, patients can enhance the ability to detect these ADRs. And now, those who had suspected an ADR in the previous month actually described the ADRs well. Disclosure of patient-harming medication errors was low by these health workers, and antibiotic-associated MEs and ADRs constituted a high burden. The pre-admission use of herbals and in-hospital conventional medicines increased the risk of hospital-acquired ADRs. Our risk scores were predictive of qualitative differences between low and high-risk cases. ADR reporting for conventional medicines should be streamlined before we can even think about introducing medication error reporting, in addition to ADRs that are linked to herbal medicines. We recommend that Uganda should develop and implement a comprehensive pharmacovigilance policy, and the voluntary forms that healthcare professionals provide, if properly analyzed, and if we give feedback to the reporters, we think that this can be an essential tool for identifying signals of medication risks. We also emphasize as a recommendation that pharmacovigilance should be part and parcel of all healthcare professional training curricula. And for the health workers, they should receive short courses moving forward. We also think that the health facilities should implement and monitor existing guidelines. For instance, on the medical wards, intern pharmacists are supposed to do bedside dispensing. So if they did this in time, then the nurses, during their ward administration, drug administration rounds, would be able to find the drugs on site at the time when they visit the patient, and then administer the drugs to avoid missed dose days. We also recommend that periodic hospital-level collection of data on medication use, as well as safety data, should be done using the ADR form we developed, or the tracking log if you want to limit on paper use. We also think that the ADR risk scores that we developed should be validated and used in routine care to triage patients who are at high risk for ADRs. Normally here in Mulago, many times the patients are admitted and they start new treatment without reconciling with what they are already taking, which can cause sometimes drug-drug interactions. The last recommendation is that testable samples of the implicated herbs should be further analyzed. Future studies would include the validation of ADR scores and the investigation of why ceftriaxone and levofloxacin had strong signals, among others. We would like to acknowledge my supervisors and all the other collaborators who made this project a success. Thank you.